morning, Mary. Are you
and
ready for that video?
Okay, let's start the video. Okay, welcome back, everyone. We're going to play a short video that will queue up in just a minute. And this is, I want to thank Baylor Scott and White for their support for this session, well, for the whole program. And I also want to thank Aon for supporting our session, our forum this year as well. It's great to have you do this. And what we're doing is, again, sponsor showcases. In this case, I'm going to thank Trent Hadley with Baylor Scott and White. I have past session on my mind still, for their support, and he has a short video that he'd like to show you.
Debbie has started a new job and enrolled in her company's newest, most innovative health plan offering. This health plan uses Baylor Scott & White Quality Alliance, or BSWQA, as the preferred network of doctors, hospitals, ancillary services, urgent care centers, and post-acute care facilities. BSWQA comes highly recommended as a strong performer for providing quality care and saving costs. The health plan benefit design requires enrollees to have a wellness exam every year with a primary care doctor practicing in a patient-centered medical home. As a newly enrolled member in her health plan, Debbie must choose a primary care doctor practicing in a patient-centered medical home and complete a wellness exam every year. Debbie is feeling a little short of breath and has put on a few pounds, prompting her to call the BSWQA Health Access Center to find a doctor and schedule an appointment. Debbie sees her doctor practicing in a patient-centered medical home. Debbie's doctor performs a routine new patient visit with Debbie. She is found to be pre-diabetic. Her doctor discusses a treatment plan with Debbie and records her health information in the Electronic Health Record System, or EHR. Now, wherever Debbie seeks care within the BSWQA network, her doctors will have access to her health information. Lucky for Debbie, the BSWQA Data Analytics Department runs sophisticated algorithms and generates reports using health plan and EHR data. Debbie shows up on the BSWQA Risk Stratification Report as a patient at risk for chronic disease. She may be in jeopardy of having a serious health event, resulting in a possible hospital admission within the year. Debbie is assigned an RN care manager who reaches out to Debbie. She introduces herself as part of her doctor's care team. Debbie is surprised to be contacted by a nurse, but is quickly put at ease when the RN care manager begins compassionately asking open-ended questions regarding her recent diagnosis and the doctor's prescribed treatment plan, and how she can help Debbie adopt a healthier lifestyle, meet her health goals, and avoid having a serious health event in the future. With the help of her BSWQA care team, Debbie has managed to stay healthy and keep diabetes at bay. She has not missed a day of work since she started her new job. But today, Debbie is not feeling well. She feels more tired than usual, and her heart seems to be beating fast. It's nearing the end of business hours. Debbie is thinking of going to the emergency room, but calls her RN care manager instead. Suspecting that Debbie's glucose levels may be low, the RN care manager sends Debbie to an in-network urgent care center near her office. At the urgent care center, Debbie is treated for low blood sugar and sent home. Debbie returns to work on Monday feeling much better. With the help of BSWQA's high-performing care team and facilities, Debbie avoids missing a day of work as well as a costly visit to the emergency room and a potential admission to the hospital.
That's great. Thank you very much. Before I turn it over to you, Lola, for introductions, I just want to say that this session is kind of fulfilling so much of what we talked about in previous sessions, where we talked about the employers are keenly interested in having employees use primary care rather than running off to a specialist before they even have anything figured out what's wrong with them. And how employers are really trying to get their employees to utilize the primary care setting more. But what we're really looking for, and what's going to be presented in this session, is kind of the dream team of primary care. And I'm excited to hear how it's actually being pilot tested here in the DFW area, a model of this. So be ready to hear about a really what I call the dream health home model. So with that, I'd like to invite Lola Chris, who is the Director of Benefits for Arcosa, Inc., and is also a long-term member of our Dallas-Fort Worth Business Group on Health Board, and works with us in many ways. And we're so pleased that you're introducing this session, Lola. Thank you.
Well, thank you all, and welcome everyone. Can everyone hear me? And I guess Marianne or someone let me know if something happens with audio. I am Lola Chris, and I am delighted to have the pleasure to introduce three exceptionally talented speakers for the session this afternoon. First of all, Trent Hadley. Trent began his career as a consultant in the public accounting industry, working in advisory services primarily with healthcare clients. In 2013, Trent moved to the Baylor Scott & White Quality Alliance to help build the financial model and focus on the performance of value-based contracts. Trent understands the complexities of the rapidly changing healthcare environment, and he effectively collaborates with internal and external stakeholders. Next, we have Misty Hambright. Misty is Manager of Benefit Strategy at American Airlines. Misty leads the benefits team that's responsible for developing and promoting health benefits programs and strategies. Recently, Misty has also been involved in American's COVID-19 testing strategy. During her 16 years with American, she's worked in various departments, including workers' compensation and benefits delivery. In addition, Misty serves, as Marianne has indicated, on the board of directors for the Dallas-Fort Worth Business Group on Health. And finally, Matt Champa. Matt is Vice President in Aon's Health Solutions Consulting practice based here in Dallas. Matt's primary responsibilities include strategic consulting and driving financial efficiency for employer-based health and welfare plans. Matt joined Aon in 2013, and he is a member of Aon's Emerging Solutions team. Matt's expertise includes developing health and welfare strategy, health plan procurement, and M&A activity. Please, everyone, let's provide a virtual welcome to our three exceptional speakers for this session. Thank you.
Thanks, Lola. This is Matt. Hi, everybody. If you can advance the slide one more for me, that would be awesome, as I'm going to kick this thing off. So thanks, y'all, for having us today. I'm really fortunate to be alongside Misty and Trent on this virtual stage. They are absolute rock stars and have an awesome story to tell. So really my job today is to help set the stage for them, and then provide you all with potentially some ideas to better support your employees, or team members, as you may call them, and their families, right? So this slide you're looking at right now was taken from Aon's healthcare point of view. And if you think of it like a sandwich with the gray bars with the yellow and green on the top of the bread and the bottom, right? And then the middle is the meat with the gray and the blue. So the top and the bottom represent, call it the foundation, right, or the base for your strategy behind the health plan. And the two things we believe employers should be thinking about is, one, manage workforce health as an investment, and then two, on the very bottom right, demand high performance from the system. So just to talk through those just very briefly, managing workforce health as an investment, right? Traditionally, employers have approached healthcare as a cost to be managed. We think there's an opportunity to shift that focus into looking at opportunities to drive business outcomes. And an example of this is think about presenteeism or productivity, right? If you're seeing in data that disability claims are a result of MSK issues, what programs can you invest in that look at prevention, risk reduction, and treatment, right? And then if you think about areas where you'd want to reduce spend, so not invest, the ineffective spend, right? High cost, low quality surgeries at places where they shouldn't be going to begin with. So just a different mindset of thinking about how the money flows. And then on the very bottom there, demand high performance from the system. I think y'all know this, there's a continuous supply of new entrants in the healthcare space. This is a very good thing. These new entrants are adding innovation and they're setting new standards for performance. But the byproduct potentially can be their increasing fragmentation. And for us to unlock positive investment opportunities, we have to drive integration and shared accountability across these suppliers and new entrants. So again, that's the outside frames of our sandwich here, and now we get to the meat, right? And on the left, we've got aligned care delivery for value. So, research kind of suggests most folks are influenced by the advice of their doctors and healthcare teams, but not in every situation are those healthcare teams incented to deliver the care in the most appropriate care setting. And sometimes it might have mean delivering the appropriate care path. So there's ways to move the needle and to get these incentives to be more aligned, which leads us into the idea that we're here to talk about today, which is enabling the health home. And a health home can be, kind of a number of things. It's probably called 1,000 different terms, but the idea of aligning the ecosystem is the perspective we're talking about. And our definition of it is an intentional, personal, and enduring relationship with a primary health professional. And that person understands the person they're treating and can oversee and coordinate their care across the spectrum of medical needs and make connections to programs and benefits offered by the employer. So you think about that, right? They have to know what programs are available through the system and through the employer, because they may be contracted separately, right? And so now let's jump to the next slide to talk just briefly about the I wouldn't say the only dimensions, but a couple of examples of dimensions of a health home that I think you'll start to see some themes pop up again as Misty and Trent go through their piece, right? So one dimension as an peer example here is single point of entry. Doesn't need to be the same person every time, but it's how does the individual get into the care system? Do they get into it the same way every single time? And once they get in that healthcare system, moving to the middle now on the top, who are they speaking with? Is it someone that they know? Is it someone that has aligned incentives to ensure that they are getting the right care at the right time at the right price, right? Which takes us over to the top right, and it's that convenient personal experience. It's not just that they have access to care, okay? It's that they have access to the care that they need when they want it. And we should be helping understand when they want and need that care based on data. So is it extended hours at clinics near a certain location, certain days of the week? Is it access to telephonic support later in the evening, earlier in the morning? Where is your workforce? Where do they need help the most, right? And data can tell us that. And then going to the bottom, starting on the left. So it's access to resources. And again, that single point of entry, providing the access to the resources, and those resources can be inside and outside of what I'll just call this health home. So again, employer may have program A, the personal health professional knows about it, and they can connect those dots for the employees. They don't have to do it themselves. And then on the bottom in the middle, it's not just physical health. We have to make sure we're talking about the mental aspect and emotional aspect of healthcare, because those are real challenges that are certainly creeping up now in light of the pandemic. And the very final box on the bottom right is the integration of care oversight. So an individual's treatment is not just a one-time event that goes away. Even though the care may be done being delivered, their interactions have a longitudinal life. And for a coordinated care to be effective, they have to know that person's history, because that may impact the decisions they've made and will make in the future. So I'll just sum it all up here with that bottom I'll call it statement. For an individual to have an active health home, they need to have a plan for health built on their individual goals and care needs that's actively managed, right? And so again, don't take this as a prescription, the only way to do it. There's some ideas that can help maybe drive the opportunity. But now I want to turn it over to Misty, and if you'll advance the slide, she can talk about their specific story they have in place here.
Thanks, Matt. So American Airlines began their journey about 2 years ago on thinking about how we could provide quality care at a better price for our team members, and thought looking locally was probably the best thing for us. You live in the Dallas-Fort Worth Metroplex, which I assume many of you do. We do have about 25,000 team members that live here. It's about a quarter of our population, so we thought it was the best place to start for us. So we surveyed the market, and we ultimately decided on Baylor Scott & White. And it's really, as you think about all the different things that they had to offer, from not just a quality network perspective with good access for our team members. When we did some geo mapping, it was a great care management team that could help provide resources for our team members kind of all in one place, whether it be searching for a provider, getting support on the medications that you're taking, or some of those other social worker items that you might need. There was a navigator service, both electronically, web-based, and app that Trent will talk about a little further in the presentation, that allowed us an opportunity to customize for our team members. So even though they may have already been seeing a Baylor Scott & White physician, they got a higher level of service and a higher level of technology as we approach this plan. And then last but not least, a fully customizable solution with Web TPA as the claims administrator, able to adjudicate claims, do prior authorizations per our mutual design of the plan with Baylor Scott & White. So with that, you can advance, and I think I'm going to turn it over to Trent to talk a little bit about our connected care plan.
Great. Thanks, Misty, and Matt, you as well, and thanks for all being here, and Marianne for having us all. It's exciting to talk about the partnership that we have continued to develop and build with American. But what we really started with is what we called, and American created this term for us, is the connected care plan, the DFW connected care plan, focused here locally for the American Airlines team members and their families in this market, and really designed to focus truly on quality, providing quality services, not necessarily just quality healthcare, although that is huge, but quality customer service and quality relationship and quality communication, with truly focused on enhancing that team member experience. If you can do those things, provide high quality care, engage the member at the point where they need something, or even before so, we believe strongly that cost will be managed in a very effective and tight way. And so we think, in terms of the triple aim of healthcare, of better experience, better quality produces lower cost. We're living that today, and I'm excited about it. When we started the plan and started thinking about how we create this and how we design this together, it wasn't Baylor Scott & White coming to American and saying, here's a prescriptive plan. It wasn't American coming to Baylor Scott & White saying, here's a prescriptive plan. It was a somewhat intense and time commitment of a development together. But the exciting part that it was a joint collaboration and a joint partnership in developing what we have today, and for something that we can offer the American Airlines team members in this market. And I think we've developed something really, really strong that has been received very positively so far. And it really started with the primary care care team, and not necessarily just a primary care physician. It's not always the need is, as Matt even mentioned, and Matt, I like the way you phrase it. It's a primary care professional, and it doesn't mean it's a physician. It doesn't always mean it's even a nurse practitioner or a physician assistant. We have nurse care managers, we have social workers, we have pharmacists. We're using pharmacy technicians to help in this model and really wrap around the team member of this broader primary care approach. And how do we do that to engage the member in a stronger way? Because increasing the engagement, we have great doctors in this market. We have great doctors in this country. But the challenge that we've seen is getting folks engaged at the right point to really manage their whole well-being, their whole health, and not get out of the sick care business and really get into the health business is our goal. And we felt like an engagement model could really support that really centered around this broader care team of care managers, really helping to coordinate things, to help navigate and advocate for the team member at every step of the way. How do we increase access and not only just expand access from access points, but how do we make it easier for the team members to access care throughout this journey? And again, focusing on affordability and where we can drive efficiencies, not only in reducing hospitalizations, reducing unnecessary uses of the ER, which we know it has been a challenge, especially in the Texas market, but how do we do so and find the providers who are the most efficient, who are doing the right thing at the right time, and as Matt mentioned, at the right place. And site of service can be a big impact to cost. And so we really tried to take these things. We designed a plan design that Misty will show you in just a minute that focused on that. And there's elements of each of these really centered around how we design this approach together. And the cool thing is we're continuing to design it. We get to work together on a regular basis. And if we see something not working, change it. If we see something working, how do we enhance it? How do we better communicate? And I think one of the greatest things we have learned, I think, together is the communication to the American Airlines team members. American knows how to communicate to their folks far better than their providers do, far better than we do. But we also know how to bring some of the engagement activities from a clinical perspective, and mirroring those together. We have seen such an increase in engagement across the board, and that partnership together to say, nope, don't use this word. You're using healthcare words. Stop using healthcare words. Use this type of language. It has made a big difference, and it has been significant in our journey of really producing this member experience for the American Airlines team members that I think, again, we will continue to evolve and we will continue to get better. But the relationship we have and been able to establish really puts that team member at the forefront, and not American Airlines, the company, at the forefront, and not Baylor Scott & White and not our doctors. It truly is focused on putting their team members and their families right in the center where our focus is. So we're excited about that. And Misty can share a little bit more on the plan design and how some of the enhancements and creation there really facilitates a lot of this model. Next slide.
Off mute. Okay. So we did create this plan with our team members in mind. So when you look at it on the right side, you'll see that it's actually quite traditional. The average age of our team member is between 51, 52 years old. They're used to certain type of health plans. They still aren't 100% comfortable with coinsurance. They think that our high deductible health plan with the $1,500 deductible is really a high deductible health plan, of which it is not. So we tried to think, again, with what our team members personally is most appealing to them. So you'll see on the right side that the goal really was to focus on a no deductible copay based plan, encouraging use of primary care, preventive care, of course, and some of the other outlets of medicine, such as our on-site clinics and telemedicine. So a great example is in some of our other traditional plans, we do charge $20 for telemedicine visits. In the Baylor Scott & White DFW Connected Care plan, we chose to charge $10. Primary care visits can range anywhere from $20 to $40 or co-insurance in our other plans. In this one, we made sure it had the lowest at $15, really to encourage that care. Co-pays even for outpatient hospitalization, inpatient hospitalization. What's also not on here is it's the same for all of the pharmaceuticals. So you will also see that we had quite some penalties related to emergency room It was $300 just flat out right if you went to an emergency room. And if it was deemed not an emergency, you'd pay an additional 40% on top of that. So the goal was really, what are our team members going to be familiar with? What's going to drive them to the correct and most appropriate site of care? And what's going to encourage them to have a relationship with their primary care physician? So again, no deductible copays for most care. Baylor did provide some priority appointment setting at many of the Baylor or all of the Baylor primary care places. It's convenient, and then there's navigation and support, which again, Trent will get into a little bit further. So with that, you can flip slides.
And I think referencing back to how we worked together on the plan design, one of the things that we really wanted to enhance on top of, what does the customer, what does the team member understand, and what's easiest for them to understand how to access their benefits, was what's going to encourage and incentivize the behavior we wanted. What's going to incentivize to engage in these primary care models? What's going to incentivize them to utilize other resources of care before they jump down into the farther road of how much higher acute or ER, or jump to a specialist just for a sprained ankle? How do we incentivize those within the plan design? And also not disincentivize care. Sometimes the high deductible plans run into the big challenge of, I just don't feel good, but you know what? I don't want to pay cash today, and so I want to wait. And there's an awesome opportunity in high deductible plans, and if you can design them and provide the member with the right resources. But what we felt in understanding the American Airlines team member population, how do we incentivize the right behavior in this type of kind of traditional EPO, HMO type model really fit into that. And we've seen the success in the engagement in primary care especially. So what we really tried, and what we really believe at Baylor Scott & White is wrapping around the team member. You'll see the team member in the middle. It's not the physician in the middle. It's not the PCP in the middle. It's the team member. And we do that with the clinical programs and the care management resources wrapped around that team member, always being quarterbacked by their primary care provider. And the primary care provider giving oversight, giving guidance, reviewing care plans, and directing the other resources to manage. But it's not just the primary care physician doing this on his own. He refers into the care management team often. He refers to his nurse practitioner or his physician assistant or social worker to help build that. And we've been able to wrap the resources around the physician to better serve the team member, which is where our focus lives. And so when you think of the different components here of behavioral health, how do we facilitate and navigate through the right behavioral health needs? Our primary care providers are leveraging and adding resources to their practice model so that they can handle many of those services, but sometimes it extends past that. It extends into substance abuse challenges, or it extends into inpatient treatment that may be needed. And we're able to support that through this broader care team, knowing how to access the system, knowing how to navigate team members, but again, all with the broader care model or the care plan that the primary care physician or the primary care team has established for each team member or the patient that they have in front of them. Transitions of care is very important. Readmissions are costly. They're largely unnecessary. And so we ensured we have the right resources to engage not only the member, but the member's family. How do we engage and support from a social standpoint around that? How do we ensure that the primary care provider is then aware of what's going on a day-to-day basis with these members? And all of that is back with the communication, back within the medical record, back within the partnership that we have really around these care teams. Some of the things that we have been kind of building on and planning is you'll see in the bottom right, a centers of excellence. Where do we look at maybe some lower volume, but very expensive procedural elements that we can identify who the best providers are. Even within our network of physicians, we know not all physician and not all facility may perform at the same level on certain service lines. And so we're working with American to identify some opportunities that we can steer patients to these high performance physicians and again, wrap resources around them from conservative treatment all the way through surgery and post-surgery to ensure that when they need something, they get it, but they get it at the most efficient and effective way possible. One of the things back that this care team really focuses on as well is how do we proactively engage these team members? There's disease management programs and all types of clinical programs that can outreach members. We believe strongly that those are best received when done in connection with their care team and their primary care physician. Our engagement rates are fantastic in that model, and it's not a nurse calling from somewhere that may not be familiar. It's, I'm part of Dr. Smith's care team. I'm part of your physician's team and really are here to support you. So we're really proactive in engaging members on behalf of our providers and really working to connect and improve that level of service. The last one here, and it'll flip into the next slide in just a second, is really how do we, on the referral and coordination, not just for, oh, I need a specialist, so I'm going to work on the referral, or I'm going to work on navigating an appointment for you, which we do directly with our team members. But what about other things? What about other benefits? What about your EAP services? What about your short-term disability? What about other programs that American has decided to offer their team members that have nothing to do with medical, but can certainly from a well-being and health perspective really help? And so if you flick to the next slide, one of the things we tried to wrap around that is our DFW Connected Care Center. So we stood up and worked with American. We had our health access team, and we really even customized that further for American Airlines and their team members, is how do we connect these members across the broad spectrum, help them find a provider, make an appointment. We can schedule appointments directly on the phone, or you can do it through the MyBSW Health app, and we help those members navigate whatever resources they may need. If they need other resources, and you could be talking to someone who, look, my son needs an orthopedic because he hurt his knee playing football. But then there's another need for another family member, for themselves, or even for that son. We can look across the spectrum and understand what the needs are and really support and help those members navigate through all of that. When there's a claims issue, nobody wants to deal with a billing issue, and no one wants to call a provider. And then, oh yeah, you know what? I was supposed to have a bill, or I got this EOB and I don't understand it. Well, we brought that all together and connected that in one spot. So whether you're dealing with claims, whether you're dealing with a pay problem or a bill issue, or you're sick and you need a nurse or you need to schedule an appointment, we really tried to put that together in an analog way. It's a phone number. It's a one-stop shop. American Airlines team members have one number to call if they need all of those resources. But we also wrapped around that with our MyBSW Health platform. And our MyBSW Health platform is one of the best health platforms in the country. It's one of the highest rated health apps. It's easy to use. It's nice. It's slick. It looks good. It's very intuitive on how to navigate. It can be proactive in reminding you on certain things for digital care journeys that the providers may prescribe. But one of the great components of the partnership with American is we were able to customize that even specifically to American. We know how the language they like to use. When they log into the app, they see their logo. They know this is part of their plan. With the partnership with Web TPA, from a TPA perspective, they see all of their claims information. They see where they're at on their deductible, which they don't have one here, excuse me. They see which claims have come through for all of their family members, not just them. They can see it for their children. They can see what they've paid, what they may still owe. They can pay a bill through the app. They can make appointments. They can see medical records. It was really just a customizable solution because we have so many team members that they don't want to talk to people. They don't want to talk to a human. They want to use the technology and they want to use devices, and they can handle it themselves and they can navigate it themselves. And so we really wanted to meet the team member where they were, find the right resources, and wrap around what we can do. The other really exciting thing when we had this type of partnership is you see on the kind of the bottom right around their Stay Well program. American had a program already established for their team members that if they elicit certain behavior and they engage in certain behavior with care managers or with nurses, there's some benefits for them on receiving their drugs, and they get no copay or a reduced copay or reduced cost for drug fills if they engage with the type of provider or the type of resource. And we facilitate that. We provide data back to American's wellness program to ensure they get that credit. And that's part of that relationship that we work together daily on to make sure all the different components, not just when you need a provider and not just when you need some type of health service, but all the needs of these members are focused on the first side. So the last slide really just wraps around that engagement platform. And we use so many different avenues to engage our team members here. And again, I mentioned on the MyBSW Health app and everything that's included there. We did a single sign-on through American Airlines portal. They have their own benefit portal for all of their benefits. And we partnered and worked together to have single sign-on so it goes back and forth. That makes it easy. It makes it easy for a team member to get what they need and it doesn't, you know what, this is too difficult, I'm just not going to worry about it. And then something happens. And so removing the friction, removing the complexity, and trying to make this as easy. We created an own website, dfwconnectedcare.com. It's a public website that any of their team members or their families from anywhere can get a lot of information about the plan, about their plan, and how to find a provider. They can schedule directly from it. And any new information we want to communicate, well, we may communicate directly, but we also toss it on the website so that if they happen to be there, they get information. And so the communication and the engagement, I think, is what has made us successful. What's so exciting about, again, we're in the first year. We're almost through the first year, and we had a pandemic navigating this first go around at this. And it's been a fun year. And we've seen the engagement in with primary care and the care team. The American Airlines population has had the highest attribution rate or engagement rate with primary care of any of the type of programs that we at Baylor Scott & White have put forth similar to this or in some relation to this. American Airlines has almost doubled some of the populations in terms of early engagement in primary care. And it's because I think we've made it easy. We've made it easy for them to do so. We've educated on the value, and we built a plan design that really incentivizes that type of relationship and gets back to what is a health home, as Matt described it. We feel like we've created this home for these team members to access care when they need it, how they need it, and make it really simple. And I think that's it. Matt, I'll turn it back over to you, sir.
And if I can just add two things to what Trent just said quickly. Not only are we having exceptionally high engagement, but it's also of all of our health plans as we normalize the data and go into 2021 with our contribution rates. It's the only plan we had that actually went down in contributions, and we actually doubled our enrollment for this plan for next year. So just exciting things to come. So just it's performing very well, not just from a financial perspective, but an employee satisfaction perspective, because word got out and more people enrolled.
Yeah, that was just terrific. Hey, a couple of questions that came up, and one for each of you. You know, Misty, if you could maybe share some insight as to how you evaluated and actually ended up selecting Baylor Scott & White and the Quality Alliance, you know, for your team members.
Yeah, I mean, it's a combination of kind of everything that we've talked through here. I think first and foremost, it was finding a partner that we could establish that collaborative relationship with that Trent talked about a lot. This was not about American telling Baylor and or Web TPA, this is what you'll do. It wasn't about Baylor Web TPA telling American, this is our plan and this is how we do things. It was about coming to that solution together at the end of the day. So I would say our comfortableness with collaboration. In addition, I think it was a combination of not only getting quality healthcare at a affordable price, but we wanted to make sure that we were wrapping everything around that team member. So it wasn't just about the physicians and where to go for treatment, but it was about that DFW Connected Care Center that we created in partnership with all of the apps and all of the other things that can help make that a great experience. So I believe, you know, from our perspective with Baylor bringing Web TPA and their application to the table, it provided us the most holistic solution for our team members so that we did not have to piecemeal anything together, if you will.
Thank you for that. Trent, one for you, and love to hear the detail that you could share on this. As you looked at serving an employer, the access to providers is super important. And when you think of a health system, Baylor, you know, is big, but did you have every single piece in that network? How did you think about a holistic network, you know, curation, you know, for serving an employer group?
Yeah, that is a excuse me, that is a great question, Matt. And when we think of the network, luckily the Quality Alliance, as part of Baylor Scott & White Health, has built a network much broader than maybe owned assets or employed physicians within Baylor Scott & White Health. We have many independent physicians that are partnered, many independent facilities. I think on Misty's slide, we partnered with Hooks and Dallas Children's and even Methodist Health System. Baylor and Methodist are like 6 miles apart and can be viewed strongly as competitors in many respects, but recognizing from a network perspective, deliver a comprehensive network, we partnered with competing health systems or competing providers in the market. And so the Quality Alliance has built a pretty comprehensive network. That doesn't mean we, the Quality Alliance, has thought of everything or for a given employer population would fit an employer perfectly. And so as Misty mentioned early on, as part of the process and the implementation, we sat down and said, look, okay, where are your team members? Where are the opportunities? Did the typical geo access standards and make sure we could meet the typical standards. But then, you know what? We looked at data and we partnered together to say, okay, what type of utilization, what type of care are these team members seeking and have sought in the past to ensure that we needed something? And there were some areas where, especially geographically, that we found some holes, and we just worked together and we found, okay, well, where are the right physicians, the right facilities, the right type of ancillary providers? And we went to the market and collaborated with those providers and got them engaged and included them in the network. And so it's not just a Baylor Scott & White network. It's not our own assets or employed providers. It's a much broader network, and that continues to evolve. We evaluate that, and we have a commitment to American that we will evaluate that network every year to ensure we're continuing to provide that level of access. And I'll mention, because this is somewhat related to a network, but it also brings in some of the COVID components. We found early on in the COVID environment back in March and April, we had some gaps from what we needed to do from testing. As a health system, testing was not readily available for the community offered by us because we had to focus on our patients and focus on our own healthcare professionals in the COVID settings and in the hospital settings. And so American had a relationship with Doctor on Demand, and we worked hand in foot with it. They weren't involved in our plan, but we connected right off the bat and started working. And when we needed to find specific testing locations or specific services related to that, we just docked in together and figured it out together. And again, that was a network component that they weren't in the network, but because we had that ability to kind of customize, and we had partners that gave us the capabilities to customize, we really evaluate that and made sure that we can provide the team members. Because again, we have built this model from a standard standpoint and from a consumer on front, but for American specifically, this was with the team members on front. And we talk about that at the beginning of all of our conversations, that we're going to, what problem do we have? What's the needs for the team member? And then we solve from there.
Oh, that's awesome. Anything else, and then Misty or Trent, as you think about, you kind of just talk through a reactive story. You reacted to the pandemic, which everybody had to do. Anything proactive you're thinking about? What's around the corner? Connected Care 2.0 kind of stuff.
I can start. I think certainly, I don't think we have big, huge changes because, again, it's early. We don't have, a full complement of data from a full year standpoint to see what are some of the challenges, what are some of the holes. I think I mentioned some of the centers of excellence work. We've started some of that, and we have some programs in place. We certainly want to expand that, not only just finding the best providers to provide a certain level of treatment, but maybe implementing some things around what's the conservative treatment option first, and maybe requiring some conservative treatment needs before you get to the acute need or the surgery need. And so, again, I think that goes into the collaboration. We look at data, partnered with both of us on that as well, and helps through those conversations. We have our own robust data analytics. American has robust data, and we bring that together. It's not us telling one story and you telling another. It's us working together to tell a consistent story and consistent find the challenges that we have. And we look at team member complaints, we look at team member challenges, and we document those and we review those together and find those opportunities. So I think, there's certainly some clinical programs that we think can squeeze a little bit more out of some waste or out of some better opportunities to better manage from a health perspective. But I think there's also things just from a member service, customer service thing. I think one of the things we continue to learn daily as a healthcare professional, and we look at patients when they're in front of us in one way and very customer focused from that standpoint. But how do we as an organization, as a provider organization, truly become a customer service organization, and not just when you're on the phone or not just when you're in an exam room or you're in a hospital bed, but how do you look at that customer and really serve those customers in a way? And I think the relationship with American has helped bring light to some of those challenges that we as a legacy provider system have had that really can help us improve how we help navigate and how we help care for our communities.
You know, one of the things when we went live back in January pre-COVID was Baylor. I call it our American Airlines Baylor Clinic. Other people can go in, but it's ours. But anyway, they opened a clinic that was within like a 3-mile radius of where 20,000 of our employees work. And our real goal there, which I think it opened in April, unfortunately, was to really, you know, start creating an environment just within where we are to think about productivity and what can we do for our team members that are all right here? What can we do for them from a conservative musculoskeletal perspective? So I think 2.0 is really finishing up 1.0 that got stopped because of COVID as we can get back into that environment. So.
Yeah. Thank you. It's a pleasure to spend time with you all today. And Mary Ann and Lola, we'd be happy to take questions from the audience if there's anything that was sent through.
Well, Ashley, I don't have any in the chat box or the Q&A box, but of course I have a question. One of the big questions I have is Misty, how do you communicate this to your employees? That you've said that it's almost doubled the number of people who are members that are, you know, buying into this, or they aren't buying in, they're getting in. How are you doing your communications for this?
Yeah, so, you know, initially pre-go live, we did very directed communications to our team members here in the DFW area. We did what we called pop-up roadshows. So we would be in different places in the work area to just answer questions, and that was in partnership with both Baylor and Web TPA. For 2021 enrollment, we actually took a very different approach, and we have a reminder postcard that goes out a few days before, well, it's supposed to land in homes a few days before annual enrollment ends. And so this year, we actually chose to move that back a bit and target those postcards. So we created certain postcards around the plans that people were enrolled in. So if somebody was in the Dallas-Fort Worth area and they were not enrolled in the DFW Connected Care plan, or they weren't enrolled in our HSA plan, which we also encourage people to get into, they got a DFW Connected Care specific postcard. We also did this year, all of our our road shows were virtual. So we did a lot of those for our DFW population. So those really were the two ways this year. I think a lot of it was word of mouth and trust. We don't, in our environment, have always the most trusting team members. In many cases, if they see something they think is too good to be true, they think it's too good to be true. And, you know, I took pride in the fact that I enrolled in the plan, and it's not too good to be true. It's actually that good. So I think it was just word of mouth of people getting comfortable that there was nothing hidden behind that plan design and the cost of the plan. Because it is our second least expensive plan out of the 4 that we offer. Just barely more expensive than our high deductible health plan.
Well, I think very attractive thing would be having no deductible. I bet a lot of people like that in this particular plan. So what percentage of your DFW employees and family are members have gone over to this Connected Care?
Oh Lord, it's Thursdays. I don't do math on Thursdays. So out of about the 25,000, we had a little over 1,000 team members enroll with 2,000 total members for 2020. And then that went up to 2,400 team members for 2022. And we have about a 1.9, I think, dependent ratio. So that's going to make it about, 4,900 or so, 4,800 total members.
It's growing and growing.
Yeah.
Sounds like, well,
it is.
To you, Trent, this, you know, with that kind of a mushrooming of you know, people accessing the care that's offered through this health home, how are you adjusting and adapting and getting enough physicians and all the other stuff that goes with it to make this really work in this marketplace? Is that a challenge? Or are you successful in bringing it all together to handle that?
I think access and primary care access is a challenge in this market for sure. And I think the things and how we created the plan design, I think to Misty's earlier point, that's why we opened a brand new clinic in the mid-cities market, and we targeted communications about that. So we opened up and added providers within, I think we opened that clinic within 9 months of when we kind of made that decision to move forward. But I think the other elements is with the MyBSW Health app and the virtual services, and especially during the pandemic. I mean, we had that ready to go prior to COVID, but that certainly has enhanced, and we were ready to take those members in, and we were already had the platform and the portal established, and it's all built into their overall health ecosystem. So I think navigating and expanding access using virtual, there's still so much resources that virtual can do and can provide it. It got up to, I think in our numbers at Baylor Scott & White, we were seeing about 60% of our primary care visits were being done virtually, kind of in the height of COVID. Previous to COVID, it was maybe 5% of primary care visits were being done. And we've probably fallen, where we'll maintain somewhere around 25 to 30% of those services are being provided virtually. We'd love to continue to tick that up. I think there's certain resources and certain opportunities that needs to be there. There's always need for in-person visits and touching and looking and having that face-to-face contact. But I think with the virtual services, with some of the digital care journeys, we've been able to do some asynchronous type services that can free up time. But I think the other part of our care model is, again, it's not about the primary care physician. It's about that care team. And so if a patient or if a team member needs something specific, they understand it. They may not be seeing the PCP or the MD or the DO that moment. They may see a nurse practitioner. It may just be a conversation with their care manager about a medication problem. And our care managers can titrate insulin. They can titrate blood pressure medicine in accordance with the care plan by the provider. So we've taken that holistic approach where it's truly a care team. And so, yeah, if Misty and the American team added all 25,000, we would have to think about how we manage that in some capacity, but it wouldn't scare us because we've built the model so that it's not solely focused on a primary care physician's access points or orthopedic surgeon's access point. It's really that care team, and we put the resources around our providers and the team members to ensure that they have that access. And certainly from a customer service and navigation standpoint, we can work and we can do after hours, and we have after hours clinics, and we have our own 7 days a week urgent care locations that we can, if it's an acute need, we have plenty of access points. And that's how we partnered, in CVS is in the network. Their minute clinics and health hubs are part of the network, and the different components that we have in different relationships. So we, again, part of and looking at that network, we don't just look at it from a geo access. There's an adequacy component to that study every year that says, okay, are we adequate from a geographic standpoint? But if a provider is full and they can't see any new patients, well, we remove them from that access so it doesn't cloud what we have. So we're expanding access in many ways, and we have to continue to do so. There's more investments that we as a health system, or we as a healthcare community or a provider community, have to continue to make. And there's other partners in the market or other friends in the market who are doing different things to do so. And that's what we owe our communities, and that's what we owe American team members, to ensure that we can provide that.
Well, I can't think of a better partner to pilot this model with than Misty, with you and American Airlines. But then Mr. are you thinking of introducing this model, perhaps with Aon's help, into other markets other than the DFW? I know you have probably have the largest workforce here in the DFW area, but I'm sure you have concentrations in other areas.
Yeah, I mean, we're looking at it. We struggle. Some of our locations are places where it wouldn't be about moving people to quality healthcare, but maybe getting them out of bad healthcare. So the strategy varies, I think, as you span across the country in some of our larger locations. Also, if you think about volatility of plans, we want to be cautious that we have the right enrollment. And our next largest location after DFW is only about 10,000. So we're reducing that population to enroll by a significant amount, which means we have to provide some pretty good incentives to get there. And obviously we're not in that financial position right now. So while we're looking at it and talking about it, and Matt will tell you, we're still talking about it tomorrow. But I don't know if it's something in the near future to for us based on our current environment.
Yeah. Thanks, Misty. That, well, you know, things are going to go slower now anyway for everything, but I think it's great that you're able to do this locally, and I'm pleased that it is in DFW. Matt, to you, a question. This will be the last question that we have a minute left to do. I know that Aon worked hard, and I want to thank you again also for your sponsorship of this forum. Are you thinking, do you have other examples of the health home operating in other areas, not necessarily similar to, or, I mean, you introduced it to here, to American and Baylor, so how about other areas or help them?
Yeah, we do. We have them in pockets all over the country, and we have them there for a variety of reasons. And you need a couple of things to come together for it to work. And so one, you need an employer who's willing to invest resources and time and think big, like American has done here, right? That's number one. Number two, you need a great health system. And that's all here, we've got Baylor, right? So there are great health systems across the country. Not all of them think as big as Trent and team are at Baylor Scott and White, but others do have that, and they're out there. And then three, you've got to have the wherewithal for the group to work together. You could have all the great pieces, but if the groups don't want to work together, it's not going to work, right? So I think that relationship you kind of saw play back between Misty and Trent and this presentation here is just the perfect storm. That's why it works so well, because they were both incented to work well and make this thing work, and it's a great result, and it'll continue to be a great result. So short answer is yes, but there are a number of components that have to come together. Yeah, so thanks for the question.
That's great to know. I wish I had time for the last question. Maybe I do have 1 minute. For Centers of Excellence, very quickly, Trent, I saw that's on your future docket. Are you thinking perhaps a cancer care first or musculoskeletal first? What would be your first one that you do?
I think with any population, we want to look at the data to see what that specific population could be most beneficial or could be most effective and get the most reward out of. I think probably 90% of employers, musculoskeletal is probably the number one. Cancer care is probably number two. Cardiac and some of the things around CV services is probably short behind there. And I think because of what we've done with the care team and managing chronic diseases, I think that we've created a model that's supported there. And I think we have to tackle some of the procedural elements and how do we do that in a more efficient, effective way. So musculoskeletal, if I think of what we've seen in most of our broader populations data, is certainly number one. And there's certainly some areas of opportunity that we've already identified there that we can do. So oncology can be so difficult and can be so challenging because there's just so many nuances within that from a patient's perspective and how they respond. I think one of the other ones, honestly, and sometimes this drives cost and certainly it drives high cost claimants in cases if not managed well. But in the maternity space, I think there's opportunities to really create some creative bundles or centers of excellence around maternity care, and not just at the moment of having a child, but the things wrapped around that. So, you know, we want to be progressive and we want to be guided by data, and I think that's important. As a provider, I have my own thoughts of what would work well. As an employer, Misty has her own thoughts, and Matt has his own thoughts. But I think what we have become a little bit more disciplined about is letting the data really speak, and we've all invested in those resources, and I think we have to continue to do so. So that's where we'll start with the data and kind of build from there.
That's great. Well, thank you all. This is a wonderful model. I wish you the greatest success in keeping it going and expanding it and coordinating, pulling it all together. And I thank you, all three of you, Matt and Trent and Misty, for sharing this information with us. It's we'll keep an eye on it. We'll be excited to hear down the line, maybe in a couple of years, what new enhancements you've added to it. So thank you again. We are coming down the home stretch. We'll begin our next session in about 5 minutes, and that will be on overcoming the obstacles and the impact of delayed or avoided healthcare. It should be interesting. I hope that you'll join us, and because we will have the grand prize drawing at the end, and your name in order to be in the drawing, needs to be listed on the on participants in this. So that was just a reminder, an incentive for you to stay to the last dog is hung. Thank you very much again for participating. Bye now.